Okay, well her stream's starting, so. She gets. I'm streaming it for her. But I lost like the bottom part that attaches here.
Not right now. Yeah.
No, I thought she meant she's streaming her live.
Right now.
Yeah, I was like,
Yikes.
It's like, are we supposed? Is this something we're supposed to watch out the like this, or?
No.
I'm confused about this.
She can hear everything you're saying.
Right now?
Yep.
Hello.
Hi.
Or when she starts the stream.
Congratulations.
On having
How
you.
cute.
Did you name it so?
No. Not so. You didn't name him someone famous.
No.
She might not be
Name
listening
it
right
obscure
now,
name so
but
that that name becomes famous.
Yes. Name it Martin.
How is that obscure?
Kelly. Which of the following neuro, like, is it in MS, you know, the side effects that you treat? Which of them use GABA? No, there's two. Sensory yeah, you got that down family. That's literally this is the only one you get.
You ready?
is that hyperaldosteronism?
Adrenal.
No, down
Yeah.
family.
Spironolactone, and then the thing with the
You
E
read this one?
Yeah.
afterwards.
I don't get when you use these things.
I just know if it's not Cushing's, then it's spironolactone.
Okay.
If it's Cushing's, it's the other
Which
stuff.
corticosteroids do you use for this?
What was it for Cushing's? It was the case.
Topic and then what case thing?
There was a case with it at the end, the Cushing's syndrome.
Dexamethasone.
I
And
don't
that's
got
the same
it.
thing you give for
We must have typed it in.
Ah.
for Addison.
Was it a hard case?
Adrenal insufficiency.
What was the answer?
It was. She was just repeating it, basically.
It's okay, don't worry about it. I don't care anymore. How many minutes do we have in between? 20? Okay.
Oh, the case was basically don't give midotone because she wants to be pregnant. And she said
Thank you guys for your
causes
patience. Sorry for
hypertension, so
technical
don't give
difficulties.
that.
I really appreciate everyone coming today. I understand that you guys have exams that were rescheduled. So what I did was for this lecture, I really streamlined it, basically cut it in half, so then it could be just the things that you absolutely need to know for the exam. And I will, because you guys are all here, I will emphasize the things that you know, that are important things. So just pay attention and you'll be okay. All right? How was the general pain management lecture, the recorded one? Was that okay for those of you who listened to it? Okay, great, awesome. First, how excited are you guys for rotations in a couple months? You should be very excited. That was my favorite part of pharmacy school. I like pharmacy school, but my favorite part, just because it showed me what I wanted to do, was the rotations. So for those of you who have me, you should be super, super excited, because it'll be a lot of fun. Okay, enough of that. So neuropathic pain. The objectives for today is to be able to recognize the signs and symptoms of common types of neuropathic pain. Now, there are a lot of types. There are a lot of types of neuropathic pain. We're going to go over 3 common ones. But generally speaking, the treatments are going to be similar. So you're going to reach for the same drugs to recommend for any type of neuropathic pain. But again, we'll just go through 3 of them. The other objective is to be able to discuss common medications used in the management of these syndromes, and then to be able to select optimal medication regimens based on patient-specific criteria. We will go over a patient case. That'll be the interactive portion of the lecture, and it'll be towards the end, so you're hopefully more awake at that point. Okay, so let's talk about the definition. The definition of neuropathic pain is that it's caused by nerve involvement. So patients will describe it as burning, piercing, numbness, tingling. Those are the type of things that you'll hear, and that's what should trigger neuropathic pain. There's peripheral sensory neuropathy and there's central pain neuropathy. So peripheral, as its name, it involves the peripheral nerves. The pain is fairly localized, and it's usually associated along a dermatome. So an example of that is post-herpetic neuralgia, which this is one of the ones that we're actually going to be discussing more, one of the common ones. Central pain neuropathy, this keeps going in and out, sorry. Central pain neuropathy originates from injury from the central nervous system, or in alteration of the processing of the pain centrally. And then the pain encompasses a larger area. Sometimes it can be experienced from head to toe, and an example of that would be, for example, post-stroke. A patient can experience pain throughout their body, or neuropathic pain throughout their body. What we'll do first is talk about the different classes. I'm so sorry, let me see if this one is working better. This one will work a little better. So what we'll discuss first are the different classes of medications that you'll be able to recommend, and then we'll go through each of the three common pain, neuropathic pain types and see where these medications fit in. So starting off with antidepressants. It's usually first line for most of these syndromes. Tricyclic antidepressants, and some of the SNRIs are used, like venlafaxine and duloxetine. The analgesia is actually independent of its antidepressant effects, and usually the onset of the pain relief is rapid. So just like when SSRIs are used for anxiety, the anxiety usually kicks on, the anxiolytic effects kicks on a little bit quicker than the antidepressant effects. Very similarly, with the neuropathic pain, it'll start working for the neuropathic pain versus the depression, which can take weeks to be seen. Some of the benefits of these medications with the TCAs, they're inexpensive and they're usually administered just once daily. For duloxetine, it can be effective in treating diabetic peripheral neuropathy, which again is one of the ones that we'll be talking about because it's one of the common pain syndrome. And it's only once daily dosing. So it's important to know, okay? Duloxetine, once daily dosing, ease of administration. Important to know, okay? Anything that's related to the heart, like side effects wise, actually not effective. So that's a good thing for duloxetine as well. And then it's favorable in patients who have comorbid depression, for example. So then if they have this diabetic neuropathy and depression, you can kill two birds with one stone, use duloxetine. Some disadvantages, usually because of the side effects. With TCAs, there's a bunch, and I'm sure you've heard this before, a lot of anticholinergic adverse effects. You see it more with amitriptyline versus nortriptyline. There's orthostatic hypotension, urinary retention, definitely more in the elderly, but you can see it really in any patient that takes it. And it does cause cardiac side effects. So again, that's a disadvantage that most of the time we don't reach for it because of that. For venlafaxine, you can see hypertension and tachycardia as adverse effects. And then for duloxetine, people can experience nausea on initiation, but you can treat through it if it's helping the patient neuropathic pain-wise. But it is contraindicated in patients with liver disease or those who drink alcohol. Any questions on antidepressants? Okay. Let me know if I'm going too fast. I drank a lot of coffee this morning. Okay, so anticonvulsants. We're actually going to be talking about just gabapentin and pregabalin, which are the voltage-gated calcium channel blockers. There are some uses of the sodium gated channel blockers like carbamazepine and oxcarbazepine, but because of their adverse effects and close monitoring and all that, unfortunately we don't see it used much. So most of the time, although yes, they can be used, those sodium gated channel blockers, most of the time gabapentin and pregabalin are going to be the ones that you see more often in practice. And so what do these medications do? They reduce central sensitization by preventing glutamate and blocking the glutamate receptors. They are used in various neuropathic syndromes, as we will see probably in anything. Whenever you hear neuropathic pain, most of the time you will hear gabapentin or pregabalin. They are administered 2 or 3 times daily. Pregabalin is usually twice daily. It can go up to 3 times, but twice daily it's still as efficacious. Both of them may cause some dizziness, some somnolence. Peripheral edema is seen more with gabapentin, and then cognitive issues. Both of them must be renally dose adjusted. So that's important to note as pharmacists, that if you are going to recommend it and these patients have any renal dysfunction, you have to make sure to renally dose adjust. And another thing to note is pregabalin, it is a Schedule 5 drug, so it is controlled medications versus gabapentin. So there is a higher abuse potential of note. Any questions on anticonvulsants? Okay, corticosteroids. So various corticosteroids can be used for neuropathic pain. The one that has been studied is dexamethasone. There are, of course, benefits and disadvantages. We know more of the disadvantages with corticosteroids, but in patients who have neuropathic pain, some of the benefits can be mood elevation, antiemetic activity, and appetite stimulation. And if it's used in the short term, the disadvantages are insomnia, some GI ulcers, hyperglycemia, and if it's used more long term, you may see some of the long term side effects like osteoporosis and the cushingoid presentation, etc. So they are usually used, and most of the time they're used just in the beginning for a flare or in the beginning of kind of this neuropathic pain syndromes, but not for too long, because again, there's adverse effects to those medications. Any questions on corticosteroids? Okay. Opioids. Opioids have been studied and shown the same efficacy as other agents in treating neuropathic pain, but they're not considered first line. As in my general pain management lecture, you've seen there's a lot of adverse effects, but even if there's not adverse effects, there is that worry of addiction and abuse potential, right? So while they can help, it's not something that's usually used first line for neuropathic pain, more as second or third or even last line. So things like morphine, oxycodone have been used for neuropathic pain. Other things that are used that have dual mechanism analgesia, so two different mechanisms that they encompass, is tramadol, tapentadol, and methadone. So that's important. Okay. So tramadol has weak mu receptor agonist activity and SNRI activity. It's been shown to be effective in several types of neuropathic pain. We'll talk about those. And it's a controlled substance. It's a C4. Tapentadol is an opioid and has SNRI activity. So very similar to tramadol, but because it has more abuse potential, it's a C2. And the ER formulation is indicated for diabetic peripheral neuropathy. So there is an FDA-approved indication specifically for one of the syndromes that we'll be talking about. And then methadone, we talked about it again in the general pain management lecture, but it's also a mu receptor agonist and NMDA receptor antagonist, and it's used off-label for neuropathic pain. So it's not an on-label use, but you'll see it in practice in low doses used for neuropathic pain, and it's also a C2. Any questions on opioids? Okay, moving right along. Some topical medications. So local anesthetics and capsaicin are effective for treating the localized areas of neuropathic pain. So if you remember from the beginning, we talked about peripheral and central neuropathic pain. So more of that's peripheral because it's localized to one area. So the 5% lidocaine patch, does anybody know the brand name of that? Lidoderm, right? The Lidoderm patches, those are expensive, very expensive. If you work in a pharmacy and try to get it through insurance, it's expensive. But it is available, and it's indicated for the treatment of postherpetic neuralgia and is particularly helpful in treating allodynia. So do you guys know what the difference is between allodynia and hyperalgesia? We'll kind of define them a little bit. Anyone know? Anyone want to take a guess? So allodynia is pain from non-painful stimuli. So someone, if they get a feather, across their arm, even though it's not supposed to hurt, but it hurts, it can hurt them. So that's allodynia. Hyperalgesia is just increased response to pain. So being more sensitive to pain. Something that does hurt, but the proportion of their response is exaggerated. Okay. The nice thing about the lidocaine patch is that there's minimal local absorption, so there's no systemic toxicity. So it's definitely much well tolerated than other medications that of course, you're going to take by mouth. And again, if it's localized, it's very helpful for these patients. Capsaicin cream is available in several strengths, and there's actually there's some over-the-counter that you could use, but there's a new approved patch that's an 8% patch, and it's available for medical office use. The way it works is it depletes substance P in the periphery, and then it down-regulates the receptors that's involved. It does, the pain gets worse before it gets better, so counseling the patient that there's going to be some burning in the beginning of treatment, and then again the relief will then be seen within 2 to 3 weeks. So that's some of the topical medications. So we talked about really an overview of some of the basics of the pharmacotherapy classes. I will be talking about some individual drugs in the some of the common pain syndromes, but this is kind of like, these are the classes that, again, you kind of go to try to recommend some of these medications for neuropathic pain. So now we'll move on to the pain syndromes that we'll be talking about. So there's 3: complex regional pain syndrome, postherpetic neuralgia, and diabetic peripheral neuropathy. So in the literature, it's actually referred to as painful diabetic peripheral neuropathy, because sometimes the peripheral neuropathy is not painful to some patients, but then once they start experiencing it, that's when, of course, it becomes a problem, and that's when we start recommending some treatment. We'll start off with complex regional pain syndrome. This is usually experienced after an initiating noxious event. It's not limited to the distribution of a single peripheral nerve, and it's disproportional to the inciting event. It's associated at some point with evidence of any of the following that is listed here. So some edema, some skin blood flow changes, allodynia, like we said before, or hyperalgesia. So you know now the difference. Could be either or. Really, the takeaway point from this slide is the etiology, with the etiology and epidemiology, is that the upper extremities are more likely to be affected than the lower extremities. And the initiating events, these noxious initiating events, include bone fractures, sprains, and trauma. Those patients have worse outcomes that have upper extremity involvement, injuries instead of just fractures, and then cold CRPS rather than the warm CRPS. So what does that mean? So really the warm is the beginning of the acute phase of CRPS, and it's more easily treated, versus the cold is the unrecognized, undiagnosed form of the disease, and it's harder to treat. Okay, so worse outcomes for these patients because we didn't diagnose it, and not we as in pharmacists, but it was not diagnosed early on. Some of the risk factors include increased age, workplace, and the type of injury. And patients with motor nerve damage are at higher risk than those with sensory nerve damage. Sounds a little counterintuitive, but not the sensory nerve damage, the motor nerve damage at a higher risk for developing CRPS. And in the literature, there seems to be talk of maybe a genetic component that may be involved in this as well, in this syndrome. So the pathophysiology, acutely, so the warm CRPS, is when there's inflammatory responses, vasodilation, and peripheral sensitization. Then, and this is all in the peripheral nervous system, then there's an increase in central nervous system concentration of these pro-inflammatory cytokines. And then again, there is disproportional response to pain than expected from the inciting injury. Trophic changes are common. Trophic changes basically is changes of the soft tissue that results from interruption of the nerve supply, blood flow to the nerve supply. There are two types of CRPS, which basically the difference between them is that the type 1, they're not really sure where the injury, which nerve is injured or if there's any injury to the nerve, but type 2, that there is evident nerve injury. This is just a model of showing you kind of the pathophysiology of once someone has this initial trauma, kind of what goes on, and we've talked about that already. But it's here for your information. And like I said, there's that genetic susceptibility. There might be a genetics component of those patients who may be more sensitive to this type of pain. The different signs and symptoms, they can be sensory, vasomotor, autonomic, and motor and or trophic. And so with the sensory signs and symptoms, again, hyperalgesia, allodynia, like we said before. Vasomotor, you will see temperature asymmetry, color asymmetry, possible tremor. For the autonomic symptoms, you can see edema or different diaphoresis or sweating changes, and reduced skin blood flow. And then for the motor or trophic changes, again, changes of the skin, abnormal nail growth, abnormal hair growth, and fibrosis. Now, this is just for you to understand kind of when someone says, okay, I have this type of pain, what type of things you'll be looking for, but you're not going to be diagnosing them. You're going to be obviously focused more on the treatment. Either way, the diagnosis is going to be mainly, and really for all these neuropathic pain syndromes, they're going to be diagnosed mainly with history and physical. There's not a lot of tests that are done or are helpful in diagnosing these types of neuropathic pain. And so the history and physical, again, are essential. Some of the tests that can be done to kind of help the provider see it, where this is coming from are listed here for you. Again, just autonomic function tests, some skin changes tests, some bone tests, but the main thing is, again, the history and physical to see when the pain started, etc. And a big thing is to rule out other causes, to make sure that we're not missing another underlying disease, another painful disease that can be treated appropriately in other ways instead of just symptom management. So how do we manage it? Some pearls to think about first, and then we'll talk about some of the medications. So to try to prevent it is key, but really this is from, again, a trauma or a bone fracture, etc. So really just being careful, but can't really do much about that. But preventing it from going from the warm to the cold is would be something that we can try to manage or help. Early diagnosis, again, and management. Physical and occupation therapy will always help for any chronic pain, which includes neuropathic pain. Smoking cessation has shown to decrease the symptoms. And then some of the pharmacological management, which we'll talk about, because there's limited knowledge of the disease, there's few targeted therapies, and some of the first-line therapies, as we'll talk about, are really extrapolated from other neuropathic pain conditions. There are some invasive therapies that we'll talk about, again, briefly, but they're just interventional procedures, some minor surgeries that can be done to try to help. But of course, with any surgery or any interventional procedure, that itself can cause pain. So a little bit a double-edged sword there. So we'll first talk about anticonvulsants. Gabapentin and pregabalin have limited studies showing specific efficacy for it, but it may offer some relief early in the course of the syndrome, but it does not have sustained release for the long-term benefit. So again, for the acute phase would be better than not diagnosing it early enough and then it going into the cold or chronic phase. For the antidepressants, it's not studied in CRPS, but TCAs and SNRIs have been used to control the neuropathic pain effectively. Again, off-label. Corticosteroids are used in large part in the early or acute phase. So this is important because in the beginning there's acute inflammatory process that occurs. It is something that can be used to treat the acute event. So corticosteroids can actually be used in this scenario. The efficacy is actually greater than that of NSAID efficacy, because if you're thinking inflammation, then any anti-inflammatory can be used, which is correct, but corticosteroids are actually, they're better to be used than NSAIDs in this particular syndrome. And again, it exhibits the most efficacy early on in the disease. So warm CRPS. Again, important. Opioids. Studies on the effects of opioids, again, are lacking. Do you guys see a theme? So far, we have not much studies at all for this specific disease state. They have shown efficacy in treating neuropathic pain when used in high doses or in combination with other agents. And so because, again, the adverse effects and the abuse potential and the opioid crisis that's going on, it's not going to be the first line that they're going to go to. They're going to try other medications first and then go to that for really intractable pain. There's another medication that can be used, but again, its use is really just for the acute phase because it's not the pain relief is not sustainable. Is ketamine. It's an NMDA receptor antagonist. And this receptor is a major part of central sensitization, so it may help with these patients with CRPS. There are a few ways of administering it: topically, orally, intranasally, and parenterally. Again, not sustainable, and then some of the adverse effects or side effects are nausea, vomiting, and psychomimetic effects. So they can experience, for example, hallucinations when using this. The most common form that causes psychomimetic effects is parenteral form. Another class of medications that can be used more for the long term are bisphosphonates. There's bone resorption at the site of inflammation of the affected limb, and that contributes to pain. And so the use of this class of medications can decrease osteoclast activity and has been shown to decrease pain. What are some examples of bisphosphonates?
Alendronate.
Good, alendronate. So alendronate, bisendronate, ibendronate. So Boniva, Fosamax, those are the brand names of them. Again, this would be more for the long term because it's not something that will take the pain away in the acute phase. It needs some time to work. Some miscellaneous agents are dimethyl sulfoxide. It's a free radical scavenger. Again, some benefit has been shown in the early CRPS. And then N-acetylcysteine has been shown to have some benefit for the cold CRPS. So for this specific syndrome, early diagnosis is key. Treating the acute or managing the acute phase is very important, because if it's not, and we wait until it's the cold CRPS or the chronic form, then it's much harder to treat. They're going to try they can try a lot of different medications, but it'll just be harder to treat in the long term. Any questions on the complex regional pain syndrome? Some interventional or other type of management are nerve blocks, spinal cord stimulation, like with electrical impulses. And then there's some intrathecal treatments which do involve some medications. These, again, this is for intractable pain. It's not something that you'll see often unless you do rotations in like a pain clinic or in a place where they're focused on pain management. So there is baclofen that can be used intrathecally. It's a muscle relaxant. It's indicated for muscle spasticity and dystonia, but again, it can be used in this syndrome. And then ziconotide, it's made from a toxin of sea snails that blocks chemicals that transmit pain. And so again, it's intrathecal, and it is for that intractable pain that has not been managed with anything else. Okay, now we'll move on to postherpetic neuralgia. Any questions on CRPS? It's hard to treat, basically. That's why it's called complex regional pain syndrome. Very complex. Postherpetic neuralgia. This arises from herpes zoster in a dermatome distribution. So it follows the nerve that's affected. And if you've seen it before, or if you've heard patients come into the pharmacy, for example, and complain about it, they usually will show you it's the nerve or the area, and it's going to be pretty defined. It's very debilitating. It leads to poor quality of life and functional status, and also the pain is difficult to control and requires multiple interventions. So how does it come about? So varicella is a viral infection that may lead to the varicella zoster on the first exposure, and then it becomes latent, and then when it reactivates, that's when you get the herpes infection, and then afterwards the postherpetic neuralgia. So the herpes zoster develops secondary to the reactivation, like I said, from the latent phase. There's a decrease in cell-mediated immunity in those patients who have immunosuppressant either medications on board, or they're HIV positive, or they have cancer. So if they're immunosuppressed, they're more likely to get to develop herpes zoster. It does occur in 500,000 Americans each year, and the lifetime risk for development of herpes zoster is 10 to 20%. And then the persistent pain, which is again the chronic form of this disease, is again seen in 10 to 20% of patients. The risk increases with age, and the incidence of postherpetic neuralgia also increases with age. We talked about the risk factors, age, but greater severity of the rash during the acute phase. If someone has more pain in that acute phase, they're more likely to have a more severe phase, in the chronic phase as well. The female gender is another factor. And then a greater acute pain severity, like we said before. One thing to note that's important is that the zoster vaccine, which I'm sure we've heard of, and especially if you work in a pharmacy, is that it has been proven to decrease the incidence of both herpes zoster and post-herpetic neuralgia. Something important to know. So what's the pathophysiology of post-herpetic neuralgia? There's two mechanisms. There's sensitization and then deafferentiation. So sensitization is when there's nerve injury and then the nerve becomes hyperexcitable and leads to allodynia. Then deafferentiation is when there's neuronal destruction, and that causes inflammatory response within the affected nerve. And then when the nerve is trying to, basically the neural sprouting or trying to regenerate, then that leads to hyperalgesia with allodynia. This is just a schematic of how the lesions or the virus will then become latent in the dorsal root ganglion. That's where the virus stays, and then when it's reactivated, it basically comes out of the dorsal root ganglion. How do you diagnose it? It's usually persistent pain within a certain dermatome, and it affects the dermatome that it innervates in a unilateral fashion. Again, there's burning, there's pruritus, there's allodynia. The pain usually decreases or resolves within 6 months after exposure, but it can persist for years. The acute phase we talked about again is the herpes zoster is characterized by a rash, then it crusts over after 1 to 2 weeks, and then results in this burning sensation. So again, this is the acute phase. There can be some prodromal symptoms that occurs about a week before. These symptoms can be headache, fever, malaise, abnormal skin sensation. And then post-herpetic neuralgia may occur 2 weeks after this presence of herpes zoster, and it's the chronic form. So what we're trying to figure out here is when did this pain start? Had they have herpes zoster? Did they get a vaccination or not? Or can we give them a vaccination to prevent this? So the treatment is separated into the acute phase and the chronic phase. The acute phase is really to treat the viral infection with antivirals. So acyclovir, famciclovir, valciclovir. This is, again, just to make sure that it's initiated in a timely fashion. And all of them are equally effective in decreasing the pain, the acute phase pain, but the famciclovir and valciclovir are just more tolerated, better tolerated than acyclovir. Using them as prophylaxis for post-herpetic neuralgia is inconsistent, so it's not something that is seen in practice. But in the acute phase, symptomatic management can be acetaminophen, NSAIDs, tramadol, opioids, and then corticosteroids are also effective in relieving the intensity of the acute phase pain, but not the duration. So that's important to know, again, where corticosteroids are used, where they're utilized, in what type of disease states. That's something important to know. So the treatment for the acute phase, again, is just the antiviral. For post-herpetic neuralgia, again, this is the chronic form of the disease. Topical analgesics like the lidocaine patch that we talked about is effective in PHN. It's safe because there's minimal systemic absorption, as we talked about. There's not a lot of drug-drug interactions, and then the most common side effect is just mild skin irritation. So it's definitely well tolerated. There are also 4% to 10% creams that are used in topical forms as well. And then the capsaicin cream that we talked about is also available, that first may seem that it's making the pain worse before it becomes better, but then once it starts kicking in, it decreases the hyperalgesia. The anticonvulsants, gabapentin and pregabalin. With gabapentin, it's just as effective as nortriptyline, but it's better tolerated. And it may be titrated up to the effect with a max dose of 36 milligrams per day. Usually it's in divided doses, usually 3 times a day. Pregabalin is just as efficacious as gabapentin, but it is better tolerated, and it's twice daily. It can be used twice daily for postherpetic neuralgia versus 3 times daily. But again, note that it is a controlled substance versus gabapentin, so it's a C5 versus gabapentin is not. Not yet, anyway. They're in the talks of maybe making that gabapentin also scheduled, but that has not happened yet. Antidepressants, TCAs have been the first-line therapy for neuropathic pain, general neuropathic pain. But again, remember the adverse effects, so it may not be the first thing to be reached for because of the adverse effects. Then the vaccine, again, is an SNRI, sorry, I don't know the typo here, SNRI. It does provide relief, again, by increasing norepinephrine, increasing the amount of serotonin and norepinephrine and inhibiting the reuptake. I'm sure you know that already in this course. It does have fewer side effects than TCAs, and so it's usually used first more, even though TCAs are first line, it's used more often because of the tolerability. But the dose has to be greater than 200 milligrams a day to have the effects. We talked about opioids and its efficacy in controlling neuropathic pain. Specifically for postherpetic neuralgia, it's controversial. But again, like we talked about, they can be used usually as later, like second or third line, at high doses in combination with other agents to try to relieve the pain for these patients. Tramadol, again, dual mechanism analgesic, can be used. And then other combination therapies can be used like morphine and gabapentin or gabapentin and nortriptyline. There are studies that show that using these combination therapies decreases the dose of both medications that are used. And then also it's better than using either of them alone. So morphine gabapentin has been studied and gabapentin nortriptyline has been studied with success. Some interventional therapy are, again, nerve blocks, like we've seen in CRPS, and then spinal cord stimulation. This can be for the intractable pain or in combination with some of the pharmacological agents. Any questions on postherpetic neuralgia? Okay, we are going to finish up with diabetic peripheral neuropathy. This is probably one of the, from the 3 that we talked about, this is the most common that you'll see on your rotations. So it's painful diabetic peripheral neuropathy. It is definitely complex as well. And it's usually in a setting with of diabetes, diabetic, right, without other causes of peripheral neuropathy. So some patients can have other disease states that can cause it, but if there aren't and they have diabetes, most of the time it is diabetic peripheral neuropathy. It's classified into 2 main categories: generalized neuropathies, so that's more the acute sensory neuropathy, autonomic neuropathy, and then focal and multifocal neuropathies that show its manifestation in the focal limb, in proximal motor neuropathy, and then more chronic inflammatory demyelinating polyneuropathy, so more of the chronic form. 56% of patients with diabetic peripheral neuropathy will complain of pain that affects their quality of life. And unfortunately, in the hospital, we see this almost exclusively. We see it more when patients come and we're talking about amputations, unfortunately. And it affects men and women equally. Some of the risk factors is the age of the patient and the duration of diabetes, duration of uncontrolled diabetes. Other associated factors are arterial hypertension, impaired glucose tolerance, And then other things that are not related is obesity, and some genetic factors can play a role. There are 3 different mechanisms, pathways, theories that are most likely act simultaneously, but they can have an overlap. Basically, with the polyol pathway is that with elevated glucose, this enters into the polyol pathway and inhibits the buffer against oxidative injury, and this causes chronic ischemia. The microvascular damage is when there's thickening of the capillary membrane, again, leads to ischemia and infarction. And then the last end product theory is, again, there's formation of hydrogen peroxide and increased oxidative stress. Some of the clinical features, there's acute sensory motor neuropathy that occurs in association with poor metabolic control, so uncontrolled diabetes or uncontrolled glycemic levels, as you see here, and then development of ketoacidosis or DKA, diabetic ketoacidosis. Either way, it's uncontrolled diabetes. And then the chronic neuropathy is the most common form. That's when you'll see, again, patients come in and complain of tingling, burning sensations. And it involves the feet symmetrically, and it just moves up. So it starts off with distally, and it moves up both feet. And like I said, when in practice, we see these patients when we're talking about, okay, now they have an infection, there's neuropathy that has been, diabetes that's uncontrolled, neuropathy that's been untreated, and then they have now an infection, and we are talking about amputations. And you will see that in practice, I guarantee you. The diagnosis is also achieved through history and physical. I mean, this really, this disease state involves the small nerve fibers. So again, there's not a diagnostic test that you can do to figure out if this is the case or not. So a lot of history and physical is important. Initial symptoms, again, burning pain, paresthesias, aching pain, and they may complain of it being worse at night. Upper extremity involvement is rare, so most of the time it's going to be their feet. And again, the providers will have this physical examination of the limbs. They're going to see if there's any sensory loss of vibration, pressure, pain, temperature perception, etc. And then there's some additional signs and symptoms that can be seen. Again, warm or cold foot, dry skin, calluses, etc. So let's talk about the pharmacological management. It's widely studied and includes use of a lot of the medications that we already talked about, so TCAs, SNRIs, anticonvulsants, opioids, and other modalities, which we'll talk about. The goal of therapy is really to protect the lower limbs from amputation because of the sensory loss, and then to relieve the pain and help the quality of life and functional status of the patient. Glycemic control is very important in those patients that present with peripheral neuropathy. This is important. It's not just going to the medications and trying to treat the neuropathy, really, and emphasizing that you can control the pain by controlling your blood glucose is very important. So treating that underlying effect or disease state is important. For anticonvulsants, gabapentin has been used as first line, specifically for neuropathic pain. It has no effect on the quality of life in diabetic peripheral neuropathy, but it does yield improvements in sleep and mental health. Pregabalin is more effective in providing relief, specifically in diabetic peripheral neuropathy, and it should be used, if medically appropriate, before gabapentin. So medically speaking, again, the way we know if it's medically appropriate or not is, again, if the patient has any signs of addiction or abuse potential, then maybe not go to the medication that's controlled, use gabapentin first. But another thing that's even more practical is the cost. So gabapentin is much cheaper than pregabalin, and so even though the patient may not have any, aberrant behaviors that we can give this controlled medication to, gabapentin may still be used first because of its low cost. And we see it all the time in practice. Gabapentin and valproic acid should be considered as alternative therapies. Again, pending the situation of the patient. Antidepressants, multiple are used, including TCAs and SNRIs with positive results, again, for neuropathic pain in general. And then the combination therapy with gabapentin increases the effectiveness specifically in diabetic peripheral neuropathy. Duloxetine is an SNRI that's indicated for depression, generalized anxiety disorder, fibromyalgia, and for diabetic peripheral neuropathy. So again, it can be, if someone has comorbid depression diagnosis, this can be used to kind of work for both disease states. And it is better tolerated than other agents. For opioids, there's many studies that have shown that they decrease pain specifically in diabetic peripheral neuropathy, but because of fear of dependency and addiction, again, close observation if they're absolutely needed, but should be really last line. And some of the examples that we've talked about the medications in general, that can be used in DPN are tramadol, morphine sulfate, oxycodone, and tapentadol. And tramadol and tapentadol are the dual mechanism analgesics that we talked about. And again, for opioids, high doses or combination therapy is usually required. The NMDA receptor antagonists can be used here because the NMDA receptor plays an important role in both nociceptive and chronic pain, and antagonizing the NMDA receptor may reduce neuropathic pain, again, generally speaking. It is used off-label, like I said before, in low doses for methadone has been used in low doses off-label for neuropathic pain. And then there have been recent studies that show efficacy with dextromethorphan as well. Some other interventions that can be used are the topical anesthetics that we talked about, like the capsaicin cream and the lidocaine patch. And then there's an antioxidant that can be used, again, because of the some of the theories that we talked about of the oxidative stress. It makes sense to try to target these pathways with antioxidants or some of the other inhibitors that you see here, but these other medications require further research before we can recommend it. But they're trying to target, again, these pathways that we talked about. Okay, everyone still with me? Okay, so we're ending with the case. Let's be as interactive as possible, so we'll go through it, and then I'll let you go. Okay, did pretty good, I think. All right, so I'll read the case. WD is a 65-year-old male with past medical history of chronic kidney disease, stage 3, uncontrolled diabetes mellitus, hypertension, and recently diagnosed deep vein thrombosis. He was admitted to the hospital after a fall. He sustained a leg fracture and was stabilized and placed in a cast in the hospital. He complains of severe pain in his leg not relieved by the as-needed medications currently ordered. Before I talk about the medications, this case brings what we talked about in the general pain management lecture and the neuropathic pain lecture as well. So medications from both of the lectures can be used for this case. So the home medications are warfarin, metformin, and amlodipine. And then the inpatient medications are to continue the warfarin, metformin, and amlodipine, and then because of the pain from the fracture, they gave him morphine 1 milligram IV every 4 hours as needed for severe pain. And that's on the numeric rating scale, score scale that we talked about from last time of 7 to 10. So let's answer some of the questions. Which opioid is a good option for this patient and why? When we're talking about PRN medication. You have to pull your knowledge from last week's lecture as well. Yeah.
PRN opioid, like oxycodone, immediate release?
Okay, so instead of morphine?
Oh, is it for like outpatient or while he's still in the
No, while he's still in the hospital. So I agree with you, but why? So I agree with you, we should probably use oxycodone, but why?
It's also oral.
Okay, oral, what else?
Morphine is hepatic, I mean not hepatic, renal impairment.
Good. Yes, so he has chronic kidney disease, we said stage 3. So both of you are correct. So use oxycodone because it's less renally cleared. And morphine can, on accumulation, it can cause seizures like we talked about in the general pain management lecture. So probably use a different opioid. But an opioid is indicated because the patient has a fracture, right? So it's okay to give an opioid in this case. Okay? What if we want to still use IV? Can we use something else instead? Yeah.
Hydromorphone?
Yeah, you can use hydromorphone as well. Again, it's not ideal to jump to very potent drugs, but if we're talking about a patient, with a fracture, they're in pain. If you are with a fracture in pain, I'm sure you want something to relieve your pain. And this is PRN. This is not something that we're going to give him for long term. Yes. Okay, so Mark said switch him to PCA. Does everyone know what that is? Patient-controlled analgesia. You can. So that's also almost as needed, but it's patient-controlled. So you have a pump that the patient will just press whenever they have pain, but it's programmed by the provider. So it's not just like endless pain medication, and they can go become depressed, respiratory depression. But at least it's there so then they don't have to wait for the nurse to try to go get the medication and then go give it to them, and then their pain is now at 10 instead of what it started out as a 7. So yeah, that can be, especially inpatient setting. Good. Okay, so which non-opioid adjuvant is a good option for this patient's pain and why? Non-opioid. So from the non-opioids that we talked about last week, what are those? There's just two classes. So I'll tell you the two and, okay, yes. Good, so there's NSAIDs and acetaminophen, okay? So from those two, if we need additional pain to help with multimodal analgesia that we talked about, from those two, which ones would be, for his case, the best? Right, why? Sorry? Kidney disease, there's a lot of reasons. Definitely kidney disease. Anything else? He's an anticoagulant, yes. He's on warfarin, so it's increased risk of bleeding, right? So NSAID's probably not the best choice, but you can use acetaminophen. Now, acetaminophen in high doses, I don't know if I have mentioned that in the recorded lecture, but in high doses, it has been shown to also increase the INR, but it's not as bad as the NSAIDs with the increased risk of bleeding. So you should still monitor them with acetaminophen, but you shouldn't be as worried because of the adverse effects of NSAIDs are basically worse. Good. He also complains of shooting pains in both feet and fingers, so we said that he's a diabetic, uncontrolled diabetic, right? So what might be the cause? Oh, sorry. What might be the cause? Diabetes, right? So he probably has this diabetic peripheral neuropathy. So what are some options available to manage this type of pain? What are some options that we talked about? Yes? Good. Like what? Lyrica, so pregabalin, good. Gabapentin, sure. Anything else? Yeah?
Control of his diabetes.
The control of his diabetes. Very good. That's important. Remember, it's important. Controlling his diabetes. Good. So for him, because it's uncontrolled at this point, definitely control it, but we also want to add some things to relieve the pain. So which class is most appropriate for him? If you were going to pick from the things that we talked about, which one would be the most appropriate? Would a TCA be good for him? What do you think? He's 65. What do you think?
No.
Probably not. Why?
Side effects.
The side effects mainly, yeah. So an anticonvulsant would be appropriate, like pregabalin or gabapentin. Depending on the insurance status, and for him, it doesn't seem like he doesn't have a lot of opioids on board or anything, so either one is okay, pending the insurance. One thing to keep in mind with the anticonvulsants is what though, in this patient? We can use it, but what do we have to do?
Renal adjust.
Renally dose adjust. Again, he has CKD. So these are the type of patients you guys are going to see in rotations. Okay, it's not going to be just one thing that's wrong with them, right? So you'll have to kind of look at the patient as a whole and see what we need to tweak, what's contraindicated, what's something that's better than one class versus the other. Okay, so the anticonvulsants would probably be the best. Gabapentin or Lyrica is fine. What counseling points should be given in regards to his opioid regimen? So if we're giving him either a PCA or oxycodone or whatever it is, what are some things that we just want to tell him about? Adverse effects. Adverse effects of opioids. Yes? Probably will cause constipation. Good. Do you need to do anything about that? Yeah, what? Both. Mush and push. You need both. Okay, so mush is the docusate, stool softener, and push is the senna, the laxative. You need both. So if he's going to be on chronic pain, again, we didn't tell you the whole story, and we're not extending the story, but if he's going to be on more long term and he's going to be on an opiate, we have to initiate stool softener and laxative to prevent the constipation, because everyone experiences that. Okay, any other side effects? Oh man, that's it? Okay. So nausea, some pruritus, long-term is hypogonadism. I wouldn't go there because we don't know if we're going to use it long-term. And then, of course, the abuse potential as well. So we can warn them that they are addictive medications, and once you don't need them anymore, kind of taper yourself down and stop, right? Especially because he doesn't really have a chronic pain medication syndrome right now that we can't manage with the glycemic control and the PRN opioids. So we're going to try to tell them for the future, let's try not to continue the opiates if we can. Okay? Any questions on the case? Any questions on the lecture? Yes? Yes? Yes. No. So I mean, it's just kind of there for your information. It's not something that I'll say in the analgesia class, the World Health Organization ladder, what should you start first? Because it's controversial. Because some people, like for him with the fracture, he'll probably need either the second or third step. He won't start with the first because he has a lot of pain. But that's just for your information. Some people use it, some people extrapolate it, some people, add another step to it. So, good question. Any other? Yes?
Are we required to know the conversion chart for the journal pain lecture?
No. Just know that it's there and that you need to reference it on rotations. That's a really good question. But no, it's not something that I want you to memorize. I don't memorize it. I look at it as well to see if we need any analgesic dosing.
Spend so much time
That's requested. Stretch. Okay, any other questions? Okay, best wishes for your exams today. You guys are going to do great. And then for your exam Wednesday, again, focus on the medications and then the different uses in the different pain syndromes. And the things that I said, it's important. Know that. Okay? Thank you guys.
Can we stay in here? Or is this where our exam is? Damn it. Dang it!